It's a great pleasure to give a talk to this faculty because I am graduated from this faculty. So, to moving on the subject, so dengue fever is caused by a flavivirus. It has a 4 serotype, but important thing to remember is the 1 serotype gives a lifelong immunity. And also it's transmitted by the mosquito, it's Aedes aegypti, and its control of dengue is mainly by eliminating the breeding places of mosquito, because at present we don't have any vaccine to prevent that. Just to highlight the burdens of dengue in Sri Lanka, from year 2000 we had about 34,000 reported cases of dengue. Of course, these are only reported cases, we have much more than that. And year 2014 up to June, we got about 18,000 cases. This is a distribution of dengue for the year 2014. As you go on, see that May and June we had a surge in the incidence of dengue fever because with the onset of monsoon. And we have so far has 50 deaths up to June in Sri Lanka from dengue. Just to go on to the natural history of the dengue, usually once you get infected by the dengue virus, there may be asymptomatic infection, which will not be noticed by anything, or the symptomatic infection is normally grouped into 4 different categories, that is undifferentiated fever, or dengue fever, dengue hemorrhagic fever, and expanded dengue syndrome. The undifferentiated fever is like any other ordinary virus infection with just fever and arthralgia, and it subsides with the symptomatic treatment. But the dengue fever, in addition to the standard clinical features of viral fever, patients have a severe bone pain and retroorbital pain. So that's a dengue fever. When it comes to the dengue hemorrhagic fever, there's a hallmark of the dengue hemorrhagic fever is a plasma leakage, which lead into a lot of complications. It might even cause death. And the expanded dengue syndrome is a syndrome where you have a dengue fever with or without leakage, in addition a selective organ involvement like liver, kidney, or brain. So coming back to the dengue hemorrhagic fever, which is very important, it has a 3 stereotypic pattern in the clinical course. It has a febrile phase, and it has a critical phase, and the convalescent phase. It's almost all the dengue fever is follow the similar pattern. So if you identify this pattern clearly, and the management will be easy. During the febrile phase, patient may have a high fever. The fever may last up to 5 to 7 days. There may be a facial flushing with diffuse erythema, especially on the skin. There may be arthralgia and myalgia. There may be a headache which is retroorbital, and associated nausea and vomiting. And some patients can present with fever and just diarrhea without any significant other symptoms. And there may be a mild hemorrhagic manifestation like bleeding from the gums, or subcutaneous bleeding, or petechial rash. And other thing is, when you do a full blood count, you will see a leukopenia with mild thrombocytopenia. That is in early febrile phase. Then this febrile phase goes into a critical phase or a leaky phase. Usually it occurs towards the end of the febrile phase. But it is important to remember that some patients, even while they have a very high fever spike, they might enter into the critical phase. The management is very important, because when you catch the patient at the critical phase, then the management should be carefully be done. Normally the critical phase starts around 5th to 6th day, that is towards the end of the febrile phase. The critical phase is the hallmark is the plasma leakage. The reason for the plasma leakage is due to an increased capillary permeability, which is very important. It is selective. In the sense, normally the leakage occurs in the pleural and peritoneal phases, and it is transient and is not due to capillary damage. So this is very important. That's a transient phenomenon, occurs selectively in few places, and it normally lasts short lasting. That is last up to 48 hours. During the critical phase, if you monitor the patient very well and maintain the vital function, then you are okay. But if you are unable to do that, then patient is going to develop any complication. Normally, the early stages you can detect by doing a hematocrit, so that normally started to rise during the leaky phase. 20% increase from the baseline indicates a patient had got a real significant leakage. During this stage, if you do a serum protein, you will find that albumin will be low. This again is a acute phase reactant. And also if you do a serum cholesterol, that is non-fasting serum cholesterol you will be doing, but we don't normally do in routine clinical practice because very expensive. We can detect this by other means. In some patients, this leakage could be minimal, or some other patients may be very significant. Normally the leakage will start slowly and increases gradually and then slows down and completely stays together within 48 hours. During the critical phase, if there is a significant leakage, the patient may go into shock. If the shock is prolonged, then patient might develop a metabolic acidosis and also disseminated intravascular coagulation. This will lead to a massive hemorrhage, right? And then that lead to further shock. So therefore, it's very important to detect this patient very early in the stages and manage appropriately. The convalescent phase is a third phase in this natural history that normally that occurs at the end of the critical phase, and normally that lasts up to 2 to 5 days. In some patients, the convalescent phase also has to be carefully managed, because if there's a severe leakage, those plasma will return to the plasma circulation and the patient might get a fluid overload and secondary heart failure. How do you detect by the convalescent phase? The patient's well-being will be improved and patient's appetite might improve. And also there is a generalized rash will appear all over the body. And also patient feel generalized itching, but of course is more marked in the palms and sole. And patients have a hemodynamic stability, in the sense the blood pressure will improve and stabilize, and patient might develop bradycardia, and patient also have a diuresis, that is all the leak plasma will return to the circulation and the patient start diuresing well. And also other way, by laboratory investigation, the white cell count will start initially and followed by the platelet count. So therefore, during the convalescent phase, initial recovery is marked by the rising white cell count. That is the last syndrome in dengue fever. It's an expanded dengue syndrome. This condition is very rare. Management is again symptomatic, but here the patient may have a dengue fever with or without leakage, and patient may have selective organ involvement like liver, that is mitochondrial hepatic failure and hepatic encephalopathy, or patient might lead to acute renal failure. Patient might develop encephalopathy or encephalitis, and there may be a cardiac enlargement and cardiac failure. Very important, patient normally develop no myocarditis. Myocardial involvement in dengue is due to a severe acidosis and hypocalcemia rather than structural myocarditis. So therefore, those patients recover completely if you manage the patient during the critical phase. So when it come to the initial diagnosis, when it comes for the first time, come to the general practitioner or a doctor on OPD level, the patient might present with fever, and the patient might have a headache, especially retroorbital. Patient also might complain myalgia and arthralgia. Of course, we have to be careful. Leptospirosis also can cause severe myalgia. So therefore, one of the differential diagnoses with dengue at the initial stages would be leptospirosis, because leptospirosis also can present with a low platelet count. There may be a hemorrhagic manifestation, and the white cell count normally less than 5,000, and there may be a rise in hematocrit level from 5 to 10% from the baseline level, and the platelet count may be less than 150,000, which is common for any other viral infection as well. So, which patient you need to admit? Normally, we don't need to admit any patient less than 3 days old of fever, but its clinical judgment is very important. If the patient comes with 1 day fever, severe vomiting, probably that patient might need admission, or if the patient has a 1 day fever, severe diarrhea, might need admission on that second day. But clinical judgment is more important. But all the patients should be admitted when the platelet count less than 100,000 to observe for dengue fever. Other features, clinical features might suggest which might need a close observation would be the patient present with abdominal pain or tenderness. There may be a persistent vomiting, or if there is a plasma leakage on clinical find like pleural effusion or ascites, or if there is a mucosal bleeding, if the patient, especially in children, if they are lethargy or restlessness, and if there is a tender hepatomegaly, those patients need immediate admission and observation. Also, if the patient is pregnant, elderly patient, and patient have obesity, if patient have a comorbid condition like diabetes, ischemic heart disease, or chronic renal failure, those patients need admission as well, because you have to observe closely. And also, if the patient has adverse social circumstances, that is, if the patient unable to come for the next day for the clinical review, and then patient need admission and observation. So, how do you manage the patient who does not need admission? Patient need an adequate fluid, oral fluid intake, and also they need a physical rest. You can use a tepid sponging to decrease the fever, and you can use the paracetamol 2 tablets 6 hourly for average adult patient, but you have to cut down the dose depending on the body mass. And also you can symptomatic manage with antiemetic or H2 blockers. And important thing is you should avoid all the NSAIDs and steroid, because if you are given, they might develop a severe bleeding and die later on. And also you should withhold aspirin and clopidogrel and diprodamol if the patient are taking, and those patients need a daily full blood count. Important thing, if the patient is admitted, you have to closely observe for early plasma leakage, and if you detect early, then you have to use a judicious fluid management. So how do you detect it early? Usually that occurs from the transient period from febrile to afebrile period, but as I mentioned previously, some patients may have a high fever, why they might straight away into the critical phase. And first thing is to indicate that progressive rise of hematocrit level. There may be a pleural effusion and ascites, which indicate patient is the middle of the peak of effusion that's already entered in the critical phase. And if the patient is unable to detect clinically, you can do a focused ultrasound scan to detect the early pleural effusion or ascites. And also if you use a right lateral decupitous view for chest X-ray, it might bring a very mild pleural effusion. If the patient develop a shock, if the pulse pressure is maintained less than 20 with a blood pressure of above 80, we can call it compensated shock. Or patient have a systolic blood pressure less than 60, but pulse pressure is maintained around 20, that we call decompensated shock. Or if there is no pulse or blood pressure unrecordable, they call the patient is in profound shock. How do you detect clinically? Patient might complain of sweating, abdominal pain and vomiting, or patient may be restless, and patient also might develop postural giddiness when they stand up, and also they might have a decreased urine output. This sign says that patient have a severe or early entry into the shock, that is cold extremities. There is a prolonged capillary refill time of less than 2 seconds, and there may be increased diastolic blood pressure with narrow pulse pressure, and the postural drop of more than 20 millimeter mercury, and also develop a hypotension of less than 8 millimeter mercury. So how do you manage during the critical phase? You have to give average about 100 ml per hour fluid, either orally or IV, depending on the patient's clinical state. That means roughly they will need about 2,500 per 24 hours. But of course, you have to take into consideration if the patient has severe vomiting, you have to give more fluid, or if the patient has a loose motion, you have to give more fluid. But of course, very important, you should not overload the patient, because if you overload at the stages, the patient may leak more and the complication will be more. Of course, there is a calculation based, which I am not going to discuss, but what you have to remember is if you detect the leakage early, the next 48 hours, patient should receive roughly about 4,600 ml of fluid during that 40-hour period, because but this fluid can be less, not more than that, because if you give too much of fluid, patient will leak more and complication will be more. But if the patient maintain the good urine output with the pulse pressure, of course, you can cut down the fluid little less than this, just to maintain the circulation and the urine output. But one thing to remember is that fluid leakage is not uniform. Some people it leaks very slowly, some people they leak very early and very rapidly and then recover slowly. So that you have to do by doing a frequent monitoring of HCT. of course, if the patient develops a shock, then of course take a blood sample and you have to give a bolus IV fluid that is about 500 ml of crystalloid, and then you can use colloid that is 40% dextran we can use, and then try to maintain the blood pressure. The fluid you can use is either crystalloid, that is normal saline or Hartmann, and colloid you have to use a dextran. Of course, if the patient is not responding to your treatment, you have to think about the acidosis, further bleeding, or hypocalcemia, and you have to do a blood sugar. Then, if it is anything, you have to treat appropriately. I'm not going to discuss about anything further, but one thing, last slide is that you can do an NS1 antigen for the first 5 days of illness to diagnose early, or you can do an antibody level after day 5 of onset of illness to confirm the diagnosis if you are doubt about the diagnosis. Thank you.